board this afternoon and thank the large number of people that have attended, not just from the council, but the voluntary sector, the health sector, and indeed our wider partners. It's obviously a really important meeting. The last time we met was at the start of this crisis on the 16th of March. And I would imagine for most of us, it was one of the last public civic meetings that any of us attended before lockdown. For people watching at home, we are conducting this meeting virtually, but obviously welcome the public in viewing what we are doing. We have a packed agenda, and I would like to thank those that have contributed to it. Given that, I will move into the formal agenda items. Elsewhere, I've paid tribute not only to those that we've lost through coronavirus, but also the contribution of everyone, I think, involved in the Health and Wellbeing Board to our response. And obviously, we're retouching not just on the impact of health inequality in our local communities in regards to COVID-19, but also our wider strategic work to deal with those inequalities as we move out of the first phase of this crisis into the second and future phases. And I think all of us involved in this work, I think the Health and Wellbeing Board has a crucial role around this agenda, and reshaping it is one of the critical priorities of me as Mayor. This is a co-chaired meeting normally, and normally I'd be handing over to Dr. Mark Ricketts from the CCG, but for a variety of different reasons, we've agreed that I will chair this meeting, and then we'll explore the chairing of future meetings. I think I've covered housekeeping before we started the live feed, but we need to stay respectful and understand the meeting agenda. And as I say, the chat function will be recorded, and please only use it sparingly. Don't get into sort of separate side conversations. Very happy to read that correction into the minutes, Raj, and apologies for that it wasn't spotted earlier. We are also welcoming a large number of people who probably haven't attended this meeting before, and I particularly welcome Claire Small from the CCG Equality and Diversity Work, and Catherine McAdam, the lay chair of the CCG's Equality and Diversity Group, and Councillor Williams to this meeting, because we know that inequalities and health inequalities especially are really important. I've got apologies to absence from Tracy Fletcher and Mahometan. Peter, do we have any other?
I have no other apologies.
No other apologies. Any apologies that want to be reported? John, I don't recall Rupert attending that meeting.
I think he was sitting next to me.
I thought that was Abdi.
Abdi, was it? No, Abdi was sitting at the other end of the table. He was doing the talk from the Somali community.
Okay, I didn't recall Rupert being there, but I'm happy to have him written into the minutes if he was. Is there anyone else? Sorry.
Chair, may I make, it's Laura here from the GP Confed, may I make a general apology that I have to go to another meeting halfway through and then come back into this meeting, so my apologies for disappearing off for a while.
Thank you. And just showing that we occasionally get things wrong with our own lead members as well, Chris has written a correction into chat around his first name too. Thank you. So if we're happy with that, that was apologies for absence. Declarations of interest. Do we have any additional declarations of interest? I'm a member of ELFT. Apart from that, anything else? If anyone spots anything as we move through the agenda, please do attract my attention, and we can accommodate that. As I suggested, we've got the minutes of the last meeting on the 16th of March. We've had some corrections already made. We're adding apologies from Navina Evans to this meeting. We noted some additions to the board, and it was my first meeting in the chair. Do we have any unresolved actions, Peter? Sorry, you're on mute.
There weren't any actions from that meeting.
Okay. Are we happy to agree the minutes?
Agreed.
Agreed.
Yeah, it's fine. Agreed.
Yes, agreed.
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 So we have nothing in the actions log, is that correct? I don't see that in the agenda pack, from what I can see. So agenda item 6 is to welcome the new member of the Health and Wellbeing Board, Malcolm Alexander, who is the interim chair of Hackney Health Watch. Is that correct? Is Malcolm on the call? John,
yes, I'm here.
You're here?
Thank you very much.
Hi, Malcolm. Do you want to just say anything, a bit about yourself and your new role and focus?
Yes, well, just very briefly, I have a great deal of experience in public involvement work, having worked in with Health Watch and other health-related organisations for a number of years. So I consider myself to have quite a lot of expertise in public involvement. I'm also a governor of Homerton Hospital, and I chair the Patients Forum for the London Ambulance Service. So I've got quite a lot of health-related interests and concerns, and I'm hoping that we could do a lot more work with Health Watch to make it into a much more effective and vigorous and lively organisation. So that's one of my commitments. Thank you very much.
Thank you, Malcolm, and I really do welcome that. And I've seen you in conversations elsewhere about
yes, you have.
Homerton.
Yes, and on the street demonstrations.
Indeed, indeed. Just for the sort of minutes, and given many of us know Rupert, just what situation things are at with Health Watch and Rupert. Is he sort of stepping back, or has there been an election, or?
Yes, Rupert has stood down for health reasons, and I've taken over as interim chair, which probably be for a period of about 6 months while arrangements are made for the election of a new chair.
Thank you. Can we make sure we note our thanks to Rupert and wish him a swift recovery, because he's had a long and distinguished civic life in Hackney, both as Health Watch chair and also before that as chair of Hackney Homes. I know he's known to many of us, and I hope you can. I'll try and make a note myself to sort of reach out and just check in on him, and not to take anything away from your appointment and what you'll bring, hopefully, as well, Malcolm. I also know that myself and several of the people on the council side are really keen to make sure that the community involvement in the Health Watch board is emphasised, including the ability to ask questions. We haven't got any questions on the agenda this afternoon, but what we do have is, I think, something from Health Watch around community voice, which is also equally important. And can I just pay a compliment to the work that you've launched as Health Watch to capture the sort of patient, community, residents experience of COVID-19. I believe you've got an active survey out at the moment, and I think that's a really welcome addition to the sort of impact assessment work. You know, we've got some very clear information from Public Health England and others, but I think this will add something really at the community level that will be really valuable as we go forward. I will now hand over to John and the community voice item, who I think is going to introduce some guest speakers.
Thank you very much.
No problem.
Yeah, thank you. Yeah, this community voice is about the unpaid carers in Hackney at the moment, and it's particularly related to COVID. But I mean, nationally, we understand that unpaid carers are currently providing more than 70% more care since the virus breakout. 35% of carers now find they are not able to access local services, or closed or reduced. They're doing an extra 10 hours a week of care. And 55% of them feel overwhelmed, worried, and are going into burnout in the coming weeks. So and we know that this is a group of people always under pressure, but the pressure has definitely increased. So I'm grateful to Nina Saunders, a carer in Hackney, and also one of my board members, Cassandra Lovelock, to speak on this issue. And I'll hand over to Nina, who will explain her situation and what she'd like to do. Thank you.
Thank you, John, and absolutely agree with you, and welcome Nina to the meeting. Sorry, it's Nina and Cassie, isn't it? Yeah, thank you.
Right, I've got the microphone on. Yes?
Yeah, we can hear you and we can see you.
Yeah, excellent. My name is Nina Saunders. I'm a carer together with my husband for our daughter Lisa, who's diagnosed with paranoid schizophrenia. A year ago, I wrote a letter to Lisa's care team documenting her then most recent admission to hospital. And I also asked a few friends and family to write a paragraph or two about Lisa, hoping it would give more insight into how life for Lisa and those around her. I stated that I feared for her safety and well-being, and the stress of it all over the last 20 years for us as a family was becoming unbearable and directly affecting our own health, and that it was our firm belief that Lisa urgently needed to be in some sort of supported housing or community 2-year recovery project. I'm going to read clips of some of the letters that I wrote. Barney Saunders, Lisa's brother. Lisa has been in and out of hospital, being sectioned. I've lost count of how many times, going in ambulances, police having to break her door or being called out. She's had one breakdown after the next her whole adult life. She's now 41 and the cycle still continues going in circles, not making any kind of lasting recovery. It's very sad to watch and for Lisa very painful. She relies heavily on my parents and me. It's like being a social worker or therapist 24/7, totally draining. Ultimately, it's never enough, and she's forever dependent on us to the point where it becomes depressing. She needs professional support, and she deserves it. Jenny Marks, Stoke Newington High Street Shop, Mind Manager. Lisa's behavior when she's very ill can become very distressing and can become dangerous to other people and herself. She's a lovely person, but she needs some help. The situation has got to the point where her family and friends have had to step back because she's not getting the help she needs. She needs an assisted home. Please help her. She needs help from professionals as we cannot give her the right care that she needs. Clip of letter to hospital and teams involved. Despite requesting help from her, she was left to get into a catatonic state, standing for many hours, unable to drink, eat, or get to the bathroom. Consequently, she soiled herself. Eventually, after the crisis team came out and gave a depot injection and left, she was still unable to move and her family called an ambulance. It took some time for the ambulance personnel to get her into the ambulance, and she was later sectioned at A&E department. We believe this should have been dealt with before it became such a crisis, and that she had been let down by the services that are there to support her. My letter to a care support worker. I've tried my very best to cope with everything, but after the days running up to A&E, spending most of the night there, I had to go to the doctor myself after the weekend for sedatives to sleep at night and medication for a massive flare-up of my stomach. Beverly Swain, 67 Manor Road, is my neighbour. I'm extremely worried about Lisa. On Monday night, she rang my bell at 11 p.m. and said she was frightened of going back to her flat because she was getting electric shocks. I assured her that she would be okay and urged her to go home. I later discovered she'd spent the night wandering the street, ringing people's bells, hammering on their doors. She's not capable of looking after herself, appeared to be hearing voices and seems frightened of being in her flat. I worry for her safety if she's wandering the streets, sitting in the pub shaking and crying, and displaying other behaviours that make her vulnerable. Red Saunders, Lisa's dad. Nina, my wife, is already on medication to try to help her cope with her own struggle in day-to-day life with Lisa. Myself, I'm a 73-year-old diabetic, and I've had high bypass ×5 3 years ago, with the constant instructions from all departments of the NHS to avoid all stress. The problem is that I can't avoid the 24-hour stress of Lisa's mental health and anxiety issues. Janet, house help. The smell in Lisa's flat was so bad I could not stay in there for long enough to help her clean and tidy it. She was clearly unwell and I was upset that I could not help her as the condition of her flat was dreadful and she must not have cleaned it for some time. Dominic, Lisa's friend and former partner. Every time that I have visited her flat, I felt genuinely despondent at the state, squalor and smell of the flat. Letter to teams involved. One night she was wandering the street until one of our neighbours took her in at 4:20 a.m. as he was terrified for her safety, but also frightened for his own safety as a man on his own. He let her in the living room whilst he went to his bedroom and shut the door. He said, "If I hadn't taken her in and if she'd been murdered in the night, the rest of my life would have been ruined." Summing up, the revolving door. She has a crisis, she's taken to hospital, patch her up, ship her back out again. No consistency, not enough time, no sufficient follow-up, no facilities for assisted housing or 2-year recovery supported housing. Endless waiting lists, no staff replacement for staff on leave or sick, no holistic approach, crowded, disruptive hospitals. COVID-19. This was all over a year ago. Since then, not much has changed. COVID-19 is catastrophic for Lisa, and she's now experiencing another downward spiral. But now we also have COVID-19 to cope with, and Lisa's dad has been shielding because of underlying health problems, which means that I must also shield. Lisa is terrified and totally paranoid with voices in her head telling her what to do. She's disconnected and she's suffering with no insight into her problem and so often refuses to engage with the help she needs. And the system is unable to cope with this. We feel abandoned, despite the best intentions of her care team. There's nowhere for her to go to be safe. The hospital environment is noisy and disruptive and is a terrifying place for her. On her last admission, her clothes got stolen. The woman who stole them was wearing them on the ward. She witnessed a nurse being attacked and got really frightened by a racist incident on the ward. She told me 2 days ago, if she has to go into hospital, she doesn't want to live. We've had her live with us in the past. We've taken her in when she went missing and had been abused and was covered in bruises. We've had detectives and police in the house due to incidents. We've had endless treatment teams and doctors through the housewives working from home. Sometime in the past, her then care coordinator asked us to take her in for the weekend and that they would follow up. 6 months later, she was still here. The value and quality of our lives have been destroyed. We've tried and tried and tried, and I really can't believe what we've been through, how much we love her and how much we're hurting. We are at our wits' end. So a little bit about being a carer. I was assessed as a carer in December 2016. I found the carer support groups extremely helpful, providing educational courses, informations, rights, outings and classes of well-being, life coaching and support as a whole, but also extremely depressing because it's clear that simply isn't a help and facilities in our society that we need, and there are so many broken people because of it. During COVID, all the NHS individuals I've been working with during this time have been amazing, lovely people, and I really thank them. We've had communication with Lisa's care coordinator, who's been going beyond line of duty, and she even rings Lisa on her days off to check on her. Thank you.
Thank you, Nina. Clearly a huge amount that you and Lisa and your family and neighbours have been going through, and I just thank you for contributing to the meeting. I just want to check that Lisa's, we're a live and recorded meeting. And just in terms of that information, you're sort of aware of that in terms of telling Lisa's story. And if there's any elements of that that you would not want sort of wider shared, because there was obviously address details given, I'd need you to sort of talk to Peter afterwards so that we could do the right editing of the video. I'm just really conscious of that. And normally in minutes, we would obviously make sure that that information wasn't shared in that way. I just had a question. Is Cassie going to sort of come in to this section, or would you? Cassie's going to come in as well. Hi. Sorry, Cassandra. Hi.
Hi.
The microphone is yours.
Wonderful. All right, that's nice to meet you all. I thought I'd introduce myself first. So my name is Cassandra Lovelock. I'm relatively new to Hackney. I think I'm the newest board member of Hackney Health Watch. I am a past mental health carer. I provided 10 years of support for my sister who had schizoaffective disorder before she passed away. And now I am a PhD student and a self-employed researcher specializing in mental health with BME issues, carers and social care. I really want to say thank you to Lisa for everything she said. I read it yesterday, but it resonates so much more strongly when you hear it from the person. So thank you for that. I'm here to sort of give a bigger picture to sort of like the intimate situation around caring, specifically as that's part of my research and part of my job. So as John mentioned in his introduction, sort of there's over 1 million carers that care for more than one person in the UK, and there's around 8.8 million adult carers in 2019 that we kept track of. I want to say before I keep going that all of the stats I mentioned have been generated by Carers UK, but when I was asked to do this yesterday, I did a quick scoping task through my own social media and my personal networks to look at and talk to carers and service users about what they've been experiencing. Seeing are like the most predominant issues in relation to COVID. Around 55% of unpaid carers are really worried about burnout, which is a really big issue. One of the main themes or issues that came out through the task, everything I read and the people I asked was about changing levels of care. So there's been a lot of issues between day centres closing down and people which would have accessed them now being home all the time. A lot of paid carers are no longer able to come into the house, or the unpaid carer and the service user have had to make the decision to not invite them in due to issues with COVID-19 and fears around things like shielding. And then an interesting point which came up with the people I asked about caring for their children was a lot of children access specialist support often through schools, and that's been taken away. So whether they have physio at school or see a therapist or a counsellor, that's all gone, and the parents are really struggling to fill that gap because that's specialist support. On the flip side of that, in terms of changing levels of care, where there's more care, people that are providing less care, I've found, are often equally, if not more stressed, as while they are providing less care due to the pandemic, that doesn't mean there are less care needs. I think a lot of mental health carers fall into this category, especially a lot more than other more physical health carers, because there's less of a requirement for us to live with the person we support. But the person we support is still having all of their care needs, but we are no longer able to go to their house and help them due to COVID-19. A sub point of that was changes in types of care. So a lot of physical health carers or people with physical needs are finding that they need more emotional support than they've ever needed before, which is actually a really difficult thing to adapt to and is very exhausting. And a lot of carers reported finding that very difficult. And then similarly, changes in care appeared around things like assisted exercise and taking someone out for a walk, or practical help at a distance like arranging food deliveries or medicine deliveries. A quick point on that was when I asked people about how the changes in the care they provided have affected them, a lot of them talked about how they have felt increasing exhaustion from providing constant mental well-being support. Things like helping someone be particularly anxious, or especially among children, hyperactivity was a really big issue that a lot of parents are having to face for the first time and are finding that really difficult. Another big worry for carers and service users, or anyone really, has been around finances and accessing benefits has been a really big part of the fear that people are feeling. I think extra food is being spent on things like money or being spent on food deliveries or household bills, and that's been particularly stressful. Someone I spoke to yesterday told me that their entire retirement savings vanished within the first 30 days of COVID, and they don't know how to cope. Further, a lot of people mentioned things like applying for universal credit and the benefit system and the fear around doing that and the stigma attached to it. And then the lack of knowledge as to how having a carer's assessment or how other benefits play into that. And then lastly, there was a point made by a friend of mine about personal budgets and how they used to spend their personal budget on their family supporting them, but now the family can't come to their house, and that's been a really big point. I quickly wanted to mention something which came up a few times, which was about bereavement and grief for carers. As if someone has care needs, they're inherently at a greater risk of COVID-19 and also, unfortunately, less likely to receive support, whether that's GP appointments or ventilators. And that has had a massive impact on the mental health of the person and also the people they're supporting. It's been really scary. And then in terms of for people that need support, there's sort of been this overwhelming sense of grief around shielding and missing out on life and mourning for the person you were before. And that's been really difficult for people to cope with, especially in their mental health. So on a more practical level, a lot of people talked about issues with not being on the shielding list, which the government produced. So especially among mental health, a lot of people have a lot of anxiety and fears of going outside, going into public spaces, but haven't qualified for food deliveries from the government and can't get any food deliveries from supermarkets, and that's been a really big issue. And then there's the expectation, especially, that carers will fill that gap by providing food and medication and hygiene products, and carers don't necessarily have that capacity or the money, and it's a really big ask that COVID's brought up. Similarly for sandwich carers, which are people which provide support for someone older and someone younger than them. So, for example, someone caring for their child and caring for a parent, they've said especially it's been very, very difficult for them because they're trying to homeschool or help their child through what is a really, really strange time, and also trying to care for their parent or their partner or their sibling at the same time, and that's been very stressful. An interesting point which came up in relation to that a few times was a lot of people had fears around their child seeing sort of the intimate and can be quite distressing nature of caring, or they've seen their child step into a caring role which they didn't previously have, helping out where the parents are, and that's can inherently be quite a traumatic thing. So I think a lot of parents are really scared about their child's mental health and then moving forward and going back to school and how having to do these things has affected their child. Lastly, which came up quite a bit, was issues around PPE for people in assisted living or supporting living or care homes, because now lockdown's been lifted in England, I think. Now lockdown's been lifted in England, there's been a lot of assisted living accommodations are now open for people to go to visit their family or friends, and there's issues around wearing PPE when you get there. Is that PPE going to be provided? If it's not, do they have to pay for it? Where are they going to get it? Is it a rule that they have to wear it in care homes or in assisted living? And that's been a really big issue a lot of people brought up. So lastly, those were like the main things which people brought up for me quite a few times, which was really helpful and also just really upsetting. I think when I asked the big question of what support do you need, a lot of people said things around more testing, of course, clearer guidelines around PPE and visiting people in assisted living or supported living. That would be really helpful. Raises in carers allowance comes up every time you ask that question, and it's completely understandable. And then quite a few people mentioned things around clear guidance of how carers allowance fits into other benefits, whether it's universal credit or particularly within the furlough scheme. Like how does carers benefit fit into that, and guidelines around that would be really helpful. Last thing, a couple of people mentioned system changes, which are always a big ask, but always really interesting. And the most common one which came up was around the need for a better communication network between health and social care services, because a lot of carers are finding themselves, especially at the moment, talking to a doctor or talking to a specialist about things like shielding and then having to relay that information themselves to their social care services. And there needs to be better communication and everyone on the same page to support carers so they can support the person they love and take care of. And then another big point which came up was about GPs and pharmacies and other like first services or other first points of call having more information for carers, especially in relation to moving forward with COVID-19, because a lot of specialist services we've seen, unfortunately, are closing down, or everyone's been furloughed, or specialist workers which work specifically with carers have been redistributed to do other things. So a lot of carers requested or would appreciate information around everything related to COVID being in easily accessible places for them to access. Thank you. Oh, if you have any questions, feel free to email me. It's fine.
Thank you. Do you want to put your email in chat if that's a sort of open request? That would be really helpful. In terms of expectations around the item, and it felt like you got an insight report there that you were sort of reading from, and just be quite interesting to understand just very briefly where the research has sort of come from, and whether that's come from some of the outreach work of Health Watch Hackney. I do have some questions, but I also know that Councillor Kennedy did quite a lot of work around supporting Carers Week and some of our outreach work and thanking carers. Now, that can in no way offset some of the deep structural challenges that both you and Nina talked about, and I fully accept that. So I'm going to bring in Chris, and then I've got Antoinette in the, Deputy Mayor Bramble in the chat, Councillor Kennedy first, and then if anyone else on the call would like to respond, and just some sort of thoughts about the next steps for what has been a very vivid description of the challenges that carers face. But Councillor Kennedy.
Cassie, thank you so much. Very comprehensive and thorough. And lots of the issues you highlight echo some of the things that we found out through our services that we've been providing as a council, especially those concerns about PPE, the joined up messaging, guidelines. I mean, we've had care home managers struggling across the course of a weekend to try and brief all their staff about guidelines that have been issued and changed on a Friday by government and have to be in place on a Monday. It's been a very confusing time. Something I remember from our Carers Week, the stat that hit me the most was that we reckon in this country there are about 1 million unpaid carers pre-COVID. During COVID time, that went up to about 6 million. So a further 5 million people experienced what it is like to be an unpaid carer. I, to my shame, had never heard the term sandwich carer, but I think many of the people who became carers for the first time found themselves in exactly that situation, looking after both children and older relatives or friends. Yeah, very insightful. I would love to perhaps catch up with you individually, and could we have some sort of link to the report and the analysis? That would be absolutely great. Thanks once again.
Thank you, Councillor Kennedy. Deputy Mayor Bramble.
Thank you, Mayor Glanville, and thank you, Cassie, for, as Councillor Kennedy said, a very comprehensive report. And just wanting to say that you may not have seen or heard, but I had the privilege, as many of the people on this call, for week after week standing out and clapping for people just like you on a weekly basis. So thank you so, so much. What I wanted to ask you about really was the information that you have access to, that you're able to signpost people to, but truly appreciate once you get into the homes, people look to you to resolve any issues that they might have, and at a critical need when they feel quite anxious, to then send them somewhere else doesn't quite feel right. But I know you mentioned things around health and wellbeing for children. I know, for example, that we have resources online, and we've launched a online service for young people around mental health and well-being. So I was curious to understand, is that information something that you have hold of? I can definitely send it to you, but I just want to think of ways that we can ensure that the services that are available are at your fingertips, so you can facilitate and signpost to get to those needs that obviously you can't fix in that given situation?
It would be really helpful if you could send me anything. I'm a sponge, like to read. So. And then a lot of the information I used in what I just spoke about came from 2 specific reports, which I can share. And then some of it came from my own personal PhD, which is not published. And then some of the work I do at my university on care specifically, which also isn't published yet. But when it happens, I can send that around.
I'm happy to pass that on to you, because we also have resources where children can phone up and speak to adults if they're feeling anxious or worried, because online doesn't work for everyone, whether it's the digital divide or people like that personal touch. So definitely can get those resources to you. But again, thank you so much.
Thank you, John.
Just a comment that we are working with the Carers Centre. I'm speaking to Joe tomorrow about kind of doing the report for carers in Hackney, and we'll be working with Cassie on that as well. So we'll be doing a report over the next month or so.
Thanks, John. I suppose it would be good to understand the flow of communication kind of coming in and out of that, and what sort of Hackney examples, what are wider examples, and where there's synergies and where we're doing better or where we're doing worse than kind of other key places that obviously hopefully place the same value on carers that we do and that Chris was articulating. It looks to me like Nina wanted to come back in. I'm also conscious of time and not really being able to do this sort of agenda item completely justice. Nina, did you want to come back in? Sorry, you're on mute. Ah, you're off mute. Oh, you appear to be off mute, but we still can't hear you. Could you try again? Nina, can you hear? No, I can't. I can't hear you, I'm afraid, and I don't know if colleagues can. No. You might want it. I'm a bit conscious that asking you to log out and log back in and then we'll come back to you might be quite tricky. I don't know if you can put anything else that you wanted to say, either in email or chat, and then if we do get a chance, we could come back to it. But in terms of process, are we saying that we're agreeing that Councillor Kennedy will convene a bit of a meeting around the build-up to the report, and perhaps meet up with Nina about some of the specifics around her case as well as an action? And then we might want to return to sort of carers support around health inequalities and the neighbourhoods type work that I'm sure we'll be touching on later on, because obviously that it is really important the needs of carers are considered in that. And I think about the types of case studies and patient journeys that we hear about so often at the ICB and how much of that chimes with what Nina had to say. If that's okay to take the item forward. Thank you really very much, Nina and Cassie and John, for bringing that to our attention. And it's very easy to forget just how hard it has been for many people in Hackney and beyond during the crisis. And I pick up on the fact that so much of that informal face-to-face, in some words, it'd be preventative, but actually it's not preventative because people have needs that are being met through those networks and those support. And I know that things like Oswald Street are reopening, having talked to Chris, some of that day centre capacity that provides obviously relief for carers too. Moving on to item 8, which is our local COVID response update. There is a paper. It also includes attached the local outbreak control plan, which was agreed under Chair's urgency powers and is also going to the ICB tomorrow, which has got our local outbreak responsibilities. I will hand over to Sandra / Dr. Husbands, depending on, to introduce the report.
Thank you very Thank you very much, Chair. Actually, we have Kate Dunn-Campbell with us, who's the registrar, public health registrar, who's been working with us on a lot of this work on the local outbreak control plan and producing our standard operating procedures, and who's actually written the cover paper and who would like to present that.
Thank you, Sandra. Yes, so I hope everyone's had a chance to have a look at the paper. It's an overview of our COVID-19 response, so an update. The main focus is really on the local outbreak control plan. As mentioned, this has been published now. It was published last week, and hopefully everyone has had a chance to read through that. So the idea of the local outbreak control plan is to outline our local response to cases and potential outbreaks of COVID-19. The plan follows quite closely the themes that were set out by national government, which I won't sort of go through each one, but effectively it's around planning for local outbreaks, making sure there's good access to testing, and also supporting vulnerable communities to engage in the test and trace process. So as Sandra mentioned, a big part of this has been developing standard operating procedures, or SOPs. And the idea is that they provide an overview of what to do if you have a case of COVID-19 and if you have an outbreak. We've drafted our first 4. So we drafted ones for care homes, educational and early years settings, primary care, and workplaces. Our workplace SOP is quite generic at the moment, and it could be sort of adapted to fit in particular workplace situations. So they provide an overview of when to contact the local authority, so the public health team within Hackney or the City of London, and when to contact the London Coronavirus Response Cell, which is sort of a joined up health protection team for the whole of London. And in developing the SOPs, we've been working closely with colleagues throughout the council and also within Hackney Learning Trust and the GP Confederation to get sort of feedback and make sure that these are useful and easy to use. To support the outbreak control plan, we've set up a City and Hackney COVID-19 Health Protection Board, and we meet weekly to discuss the plan because it is sort of a dynamic plan and it will be updated as situation changes and as guidance is updated. In terms of testing, so we have a mobile testing unit in Hackney, which is at Bentley Road Car Park. We are hoping to increase the frequency that this is available. At the moment, it's available 3 days a week. And we've been working, addressing some of the difficulties that some residents might have in accessing testing. For example, not having access to the internet or a mobile phone. And to support both the testing and contact tracing process, we've been working closely with the community and voluntary sector. Our idea is to hopefully provide training and develop community champions who will support local groups to build trust in the NHS test and trace process and to know how to access accurate information and where to go if they have any questions. So I think that's sort of it from my update. Any comments would be really welcome, and I hope everyone's had a chance to read through the local outbreak control plan.
Thank you, Kate, and thank you, Sandra, for introducing it. I think we were on time from what I recall as well. I know there was some talk about local authorities, and I think the fact that we're part of that good practice network, and I know some of us have come straight from that meeting, has kept us regularly in meetings, but also provided a good set of steers. There's obviously still a lot around data and other issues that need to be resolved, but I think it's an incredible piece of work, and it's good to sort of share it with Health and Wellbeing Board colleagues. I'm assuming that the discrepancy between the circulators, we circulated papers in time for this meeting, but then we're honing and signing off the report that's now available.
Yeah, that's what happened. So apologies, colleagues, but it was just about the timing of having to submit something for this board.
But I think you've very helpfully said that it's never a finalised version. It will be constantly honed as we move through the next stages. And I think that's a helpful spirit, that it is a work in working document and framework in which to hold this piece of work. Raj, you asked a question earlier on. I'll bring you in, and then if people want to indicate in chat if they want to come in.
Thank you, Philip. Appreciate and apologies about putting it on the chat. Didn't realize the format, but yeah, learning as we are learning a different way of working online and things like that. Yeah. So yeah, just feedback going to the planning about the multi-agents working. It would have been, I think you would have found of value if your community pharmacists involved in this. We're probably the only people that were open during this whole lockdown. We're completely inundated with people walking in all the time. Would have been good to have had input in the plan and see where we could have contributed. We did work with the voluntary sector and the CCG in order to plan where people are shielding and how to organize voluntary workers to come and deliver the medicines and things like that. So yeah, and looking at the SOPs, I think you've done great for the care homes, educational settings, workplace, primary care. I think you mentioned that it's a working document, things are evolving. Good to have community pharmacies on there. If they do shut because they've been told to shut down, it could have great implications for local services, people's prescriptions, things like that. And that's where I'm coming from. Think about test and trace again. If we can be of value, because community pharmacies are used quite regularly by a lot of people, it could be an access point in terms of information and how that could work as well. Just think about another resource you could use. Yeah, and yeah, that's what I wanted to catch up on. Thank you.
Thank you, Raj. Does anyone else want to come in before I go back to Sandra? The only reason I sort of mentioned coming in was just Nina was at a very poignant moment, and I was just trying to make sure we didn't go off down a rabbit hole while Nina was speaking earlier on. I'll bring in Mark, and I've also posted in the chat the public version of the Outbreak Control Plan, which, as you can see if you click through, is version 2, which shows the iterative process in action. Mark.
Oh, that was that was one of my 2 comments actually, just to how we get access to the public version, because I can see that I was similarly blocked or couldn't do it. I guess one thing I've just been discussing with CCG GP colleagues mostly, who actually happen to be the ones who mentioned it, in the context of seeing patients who are finding it very difficult to access testing when they were symptomatic or worried that they were developing symptoms, in order to get to use the telephone line, the 119, or the online offer. Now, I appreciate that's all nationally mandated and there's not much flex on that, but they're increasingly worried by people who couldn't either speak English very well or didn't had other sort of impairments, which meant that they found it difficult to actually access it. And I spoke about the fact that you've got the community champions trying to, locally at least, to try and connect them with people who might have those problems and be struggling to get access. But it's obviously a real challenge to actually connect those 2 people together. And the colleagues on the call I was just on were saying, "Oh, right, yes, I kind of knew that rings a bell, but I don't know how do I quickly ring a community champion if I've got somebody here with me, or I'm on the phone with them, or on a video call, or whatever else it might be." So I was just wondering how that is going. And also, because one point is, of course, once a community champion gets known within the community, then hopefully the connection is immediately made. And I guess we don't know, how do we know if that's happening increasingly or not? So how would we know? I suppose it's about people being able to access people like that to help patients or clients, and also how will we know how effective they are in going about this part of their role.
Thanks, Mark. Do you want to take those 2 points?
Yeah, thank you. I'll respond to Raj first. I thank you very much for those points. Actually, they're very well made, and I think you're right that it would be really valuable to have community pharmacy involvement in the further development of the plan, and particularly that we should be considering developing an SOP for community pharmacies. They clearly won't all, unless we have a local lockdown, they won't all close at the same time. But even if one closes in a particular area, it could have impact for the community. So I think it's really important that we we understand what that means, and the pharmacy itself, as well as the local public health team, everyone understands what needs to happen. So would be delighted to work with somebody. Either you could suggest somebody from the LPC, you might want to join us yourself, but we can take that outside of the meeting. And then in terms of the community champions, Mark, those were all really good points. It's early days, very, very early days with the champions, and we haven't done the training with them yet. We're hoping to do that later this month. But connecting the champions with individuals from their own communities, but also connecting them with different parts of the system, like health service and social workers and other people who can connect people who need support together, is going to be really important. So happy to come to the CCG to talk about how that might work better as well. And the GP Confed, of course.
Thanks.
Well saved there, Sandra.
Thank you.
Thank you. I'll bring in Malcolm.
Microphone is off.
Malcolm, you're on mute.
On page 20, section 3.3, there's a reference to detention of individuals who pose a risk of infection. And I just wonder under what circumstances somebody might be detained, how it would happen, where they would go. And it seems to be a rather excessive action, since so many people theoretically could be highly infectious in a way and could pose a great risk. I wonder under what circumstances a detention, by whom that detention would be made.
Well, you're right. It is an excessive, but it's the sort of thing that it's an extreme measure that would only be taken in extreme circumstances. In the context of COVID, it's not really clear whether we would ever need to use those powers, because, as you said, a lot of people have it. But it's this kind of circumstances where you know that somebody is infectious and are posing a risk to other people, and are refusing to take the appropriate action to reduce that risk to other people. Those powers have existed for a long time and have been used in the past, for instance, to keep people who have TB in hospital. Yes. And they're usually detained in a place of safety. They're not banged up in prison or anything. So it's like they're taken into hospital and they're isolated appropriately. And where possible, if they are given appropriate treatment. You know, so if a treatment exists. So, so for in this particular instance, if they were, if they have COVID and they're well enough to be going around infecting people, then they're probably not going to be ill enough for the one treatment that we know is effective. But they might still need to be detained in extreme circumstances to prevent them. You know, if they happen to be somebody who was causing lots of infectious events, if you like. But
this would be a police detention, would it?
Oh, no, sorry, it's a public health power, and we would work with our colleagues in Public Health England, and the power, the specific power, is invested in the consultants in communicable disease control who work for Public Health England.
Okay. Thank you very much.
Thank you. I think in the last meeting we discovered that the situation in Leicester was is the use of Secretary of State rather than DPH in public health powers, and the lockdown that's sort of been imposed there. And there's still an onward debate about how the powers in this report would be used in comparison to those that are used centrally in the COVID Act. I did notice that Catherine had talked about the standard operating procedures and where they're located. I would have provided an easy answer to that, but couldn't find them myself. And again, Mark says they're not in that version of the docs.
No, so they're not in that version. So we had a deadline to get that particular plan published, and then so we did. And as you know, it's a dynamic plan and will be refined. And so we've been working on developing and refining the standard operating procedures, which are really so these are the bones of the plan, really. These are the things that for any specific setting or circumstance are really going to make the plan work or not work. And but we need to make sure that those are absolutely right, and that they've got all the most appropriate technical information and up-to-date evidence and the key contact details in them before that they are published. Otherwise, they're not any use. So that's what we've been focusing on over the last week or so since the plan was published. And they will, we will start to publish those as they're signed off, and they'll go on the website as well. And as they are published, we'll be communicating those to the relevant settings.
Thanks, Sandra. And we're doing this obviously slightly again tomorrow with the actual local outbreak board in the morning as part of the ICB program. I presume after that process we'll be in a better place to sort of communicate more widely this sort of work. I know there's obviously been communication, this is communication, but did anyone else have any questions or comments either on the outbreak or the sort of introduction report that it sat with inside of? Councillor Kennedy.
Just wanted very quickly to thank Sandra and her team for the very quick hard work that has gone into this and the ongoing work, especially with the community sector and working with the community champions, and welcome the commitments we've just heard to bring even more people into consideration for those processes. Thank you.
Thank you, Councillor Kennedy. And I echo that thanks. And I know that we'll be seeing more and more of this work more visible during the course of July and August, and the communications that wrap around it, and the onward discussions about testing and data roll on as they have done throughout the crisis. But I think Bentley Road has worked incredibly well, and I do thank the public health team for the work that they've done around that and making it as much as you can a sort of Hackney testing centre while recognising that it's run nationally. I will now move on then to the next agenda item, which is item 9, which is the health inequalities and impact of COVID-19. And there's a slide deck here, and my understanding is that Kirsty Bell, Public Health Registrar, will introduce, alongside Christopher Caden, who's within Sandra's Public Health team, and how we're looking at health inequalities. But obviously there are the national data that sits alongside this and a bigger and broader national debate, which I know that Councillor Williams, Councillor Kennedy and myself have put ourselves firmly at the heart of.
Before Kirsty starts, can I just add that Diana Divieva, who's our Principal Public Health Analyst, will also come in at the end with some further information on work that's been done since this presentation was finalised.
That's really useful. Thank you, Sandra. I'll hand over to the team.
Thank you very much. So as you already said, so my name is Kirsty. I'm one of the registrars in public health and the Hackney Public Health team. Both Chris and I have done some work over the last few weeks to think about both inequalities and the information we have on health inequalities nationally, and to look at the evidence base that exists there, and then also, as Sandra says, to think about how that applies locally, and to try and look at other sources of data we might have locally to think about, where we might want to focus some of our efforts going forward. In particular, I note that Jane Taylor has also been doing some work specifically thinking about health inequalities with the Health and Wellbeing Board, and hopefully some of this information will help feed into that process. But we are also asking, as we go through this presentation, for members of this group to think about how some of this might apply to your work, and also we're very happy to field questions on how some of this information might support others in this meeting. So I'll hand over to Chris to introduce with the start of the slides, and we will address different parts of the slide pack between us both. And Chris is going to share his screen now, so hopefully you can all see that in a couple of minutes.
Can anyone let me know if that's not coming up on their screen?
It's working.
Okay. Yes, good afternoon, everyone. I'm Chris Caden, and I work in the Council's Public Health team. I'm going to run through this briefing paper that Kirsty and I have been working on over the last couple of months, and it's really looking at the emerging evidence around COVID-19, both the pandemic and the resulting lockdown, and the disproportionate impacts that these events are having on some communities. As a recent Public Health England review into disparities in the risk and outcomes of COVID-19 concluded, the impact of the pandemic has replicated existing inequalities and in some cases has increased them. What we're going to do throughout this presentation is talk about both the pandemic and the lockdown, and we're going to discuss what the national evidence is telling us about different risks for different groups. So those groups are older people, people living in care homes, people of certain ethnicities, the impact of deprivation or the risk of dying from COVID-19, as well as gender and occupation as well. We'll supplement that national evidence with what local data and insight is telling us to produce a better understanding of the different levels of risk for communities in Hackney. There's quite a lot of evidence in this briefing paper. We're not going to talk through every paper that we've looked at, but we'll draw out the headline findings from our research, and we've included links throughout the paper, so we're signposting you to the literature that we're discussing. And just before I get started with the main bit of the briefing paper, to be clear, this is an exhaustive document. There'll be much more data and evidence coming out in the coming weeks and months, which we'll need to keep track of to ensure that we're maintaining a really good understanding of COVID's effect on inequalities. So looking at the risk to older people, the evidence is very clear on this, that older people are at much greater risk of dying of COVID-19, with a number of papers saying that mortality rates rise sharply after the age of 60. This may reflect that older people are more likely to have multiple comorbidities, which puts them at greater risk. In addition to this risk of mortality, there's also the impact of lockdown, which is having a disproportionate impact on older people. There are concerns about the well-being of older people as a result of lockdown, with older people reporting that they're more likely to experience loneliness during lockdown compared with younger people in the population. And older people have also expressed greater worry about how the lockdown is affecting their well-being. In addition to that, a number of voluntary and charity national organisations have raised concerns about the effects of lockdown relating to physical and mental well-being, particularly the effects of long-term restrictions on social interactions as a result of this older group in society having to shield. The local data that we have clearly reflects what the national evidence is telling us, with older people at a much greater risk of dying of COVID-19. What we're seeing is that the death rate within age groups increases sharply for older age groups, with the risk rising more steeply for men than for women. And on the effects of impact locally, HCVS has raised a number of issues which they've heard through their neighbourhood conversations in recent months. One of which repeatedly comes up is the issue of a digital divide for older residents who might not have the capability or the access to use digital equipment, and this might affect how they access support services or how they engage with public health messaging. Similarly, HCVS have talked about what the national organisations are talking about around concerns of prolonged isolation and its effect on physical and mental health. Prior to lockdown, we also know from City and Hackney's JSNA that older residents are much more, they're at a higher risk of experiencing social isolation, and we believe that this is probably likely to be exacerbated over the recent months. Related to old age is the impact of COVID in care homes. So the King's Fund carried out some research which showed that the week up until the week ending the 1st of May 2020, the mortality rate in care homes was significantly higher in March and April than it was in recent years. Death rates in care homes were high, and they also started to decline somewhat later than the death rates that we saw in hospitals. If we look at the care home situation in Hackney, Hackney saw a relatively low proportion of deaths in care homes. We think this reflects the relatively low proportion of Hackney's older population who live in a care home setting. However, I should say that all 4 of Hackney's care homes did report at least one case of COVID-19, and we'll need to consider how we ensure these settings are resilient going forward with the potential threat of future outbreaks.
Okay, so moving on then to ethnicity and reviewing the national evidence on this. So several studies have pointed strongly towards there being differences between ethnic groups in terms of both the risk of having COVID-19 and then also the risk of mortality. So you can see there we've included studies from the IFS, ONS, Health Foundation, Open Safely, and then notably the PHE report that was published a few weeks ago. These studies have shown that people from Black, Indian, Pakistani and Bangladeshi communities do appear to have a greater risk of dying from COVID-19 even after adjusting for various socio-demographic factors. So when we've accounted for other explanations, then ethnicity still seems to be an explanation. It still seems to be pointing towards ethnicity as something that's coming through as a significant difference. Public Health England, as I said, have reported that Black ethnic groups were the most likely to be diagnosed with COVID-19, and additionally PHE has found that death rates from COVID-19 were high amongst people of Black and Asian ethnic groups. We've included here that the point that PHE has made is that this reverses the trend that we have seen in previous years, which is where white ethnic groups have had higher mortality rates. So this is the increase in the death rates of COVID-19 amongst Black and Asian groups is against a backdrop of there being higher mortality rates in white groups in previous years. There have been, to be very clear, there's lots of information out there about the likely drivers of this, and there doesn't seem to be consensus. We have included in this section an ONS evidence review, which has highlighted differences in overcrowding. We don't know the extent to which this has a bearing on COVID-19 outcomes, but it does suggest that white British households experience far less overcrowding than households from, for example, Bangladeshi, Pakistani and Black households. So some quite significant differences there, and there's a suggestion that this might impact upon transmission, ability to socially isolate and those sorts of issues. We have also looked at the data regarding ethnicity on the impact of lockdown, and we have also found some interesting and obvious patterns. So what we found, according to the IFS, the economic impact of lockdown may be more significant in some ethnic groups. And what we've included here is that Bangladeshi, Pakistani, Black African and Black Caribbean men are more likely to work in lockdown sectors. So to perhaps work in occupations where you're continuing to go to work, or perhaps also be in sectors where work stops. So we've also found that Bangladeshi, Black Caribbean and Black Africans were more likely to have limited savings to fall back on. So suggesting that some of the economic challenges of lockdown will be particularly pronounced in those groups as well. The Fawcett Society has done some surveys, some survey work, and again suggests additional pressures on Black and minority ethnic groups. So just to give you an example, in one headline of this study showed that 42.9% of Black and minority ethnic women said they believed they would be in more debt at the end of the pandemic compared to the start of it, and this is compared to lower rates amongst white women and white men, with white women at 37.1% and white men at 34.2%. So very clearly what we're seeing in the national evidence is higher case numbers amongst people from ethnic minority groups, higher cases of higher mortality rates, and then perhaps a disproportionate impact of the lockdown. So then, looking at our local data, I'll start by explaining that our local data is made available to us largely at the moment by country of birth, and we recognise that that is a poor proxy for understanding the impact on ethnicity and different people from different ethnicities. But I will go on to talk about that data anyway, but with that caveat in mind. Some research that has been done locally that does consider ethnicity is some research by some academics at the Queen Mary University of London and King's College London, which looked at presentations to GP practices, and that is across across the patch in East London. So that's City and Hackney, Newham, Tower Hamlets, and Waltham Forest. The paper concluded that there was a twofold increase in the odds of infection for South Asian and Black adults compared to white adults. So what that shows is that we are seeing locally this disproportionate rate of being infected with COVID-19 amongst certain groups compared to white adults. Then what we have also seen is we've reviewed some of our joint strategic needs assessments. We're aware from that Black and minority ethnic communities do in some areas have higher rates of underlying conditions that may contribute to worse outcomes from COVID-19, including diabetes and CVD. But we have also found that white groups have higher rates of COPD and asthma. One important point to make in all of this is we are very aware that underreporting of certain conditions may also affect our understanding of some of these underlying conditions. So we may know about rates of asthma in certain groups compared to others. So that may reflect an unmet need. The impact of lockdown, in terms of that understanding locally, some work has been done within the council to think particularly about the impact of lockdown on the Hackney community, and we are aware of some concerns that have been expressed about lockdown being enforced unfairly. So particularly in linking that to historic discriminatory impact of stop and search on Black and minority communities. And how that impacts upon people's fears and perceptions of how the lockdown has been or will be enforced. There's concerns expressed to us about the mental health aspects of lockdown and how that might impact groups within the community disproportionately, and that the mental health concerns are both in the short term and also in the longer term going forward. We're also very aware that within the community, different groups may have different access to digital services, which we need to be very mindful of as we move forward with track and trace. As I said, I am going to show you the data on place of birth, but we are very aware that this doesn't equate with ethnicity, but it does nevertheless paint a very striking picture, in that of the 220 deaths that we've sadly had in Hackney between the 12th of March and the 17th of June, 66% were amongst residents who were born outside of the UK. In comparison, only 37% of residents who died were born in the UK, and you can see on the chart that's provided, and apologies, it isn't the clearest diagram, but you can see the proportion of where people have been born and against deaths. So the proportion of the entire population in the left column, and proportion of deaths from COVID-19.
Sorry to interrupt your joint flow. I'm just slightly conscious of time, and making sure there's time for questions and also Diana to come in. So I think if you can pick out some highlights, that would be great.
Yeah, we can quickly go through the next. I think we'll pick up highlights from the rest of the themes, Chris, if that's okay.
Sure. So on the next point, there's a clear link between high levels of deprivation and a higher rate of mortality from COVID-19, with the ONS predicting that this is twice as high. The mortality rate is twice as high in the most deprived area compared to the least deprived area. We are seeing impacts of lockdown, disparities of impacts of lockdown, with people in lower socioeconomic status jobs having reduced opportunities to work from home. For children, there are educational inequalities which are coming about, lack of resources to complete schoolwork, and students from poorer backgrounds, also the quality of their work decreasing. The Children's Commissioner that has raised issues around 2 million more children being vulnerable as a result of lockdown, and the Food Foundation has reported that for adults, food poverty has quadrupled as a result of lockdown. The local data is reflecting somewhat the national picture around death rates. So of all deceased in Hackney where an occupation was known, 47% of deaths were among people employed in routine and manual occupations, and this is in contrast to around 32% of Hackney's population being in routine and manual occupations. Again, with deprivation, what we're seeing as a result of lockdown is food poverty being an issue, financial issues being an issue, which we're seeing with an increase of universal claimants, and again, from those HCBS neighbourhood conversations, ongoing concerns around digital divide for the most vulnerable in Hackney's community.
So the slides Chris have just presented on deprivation, so this is some extra information on occupation. One thing I'll flag from this slide is what we have seen is for both men and women, care workers having the greatest risk of dying from COVID-19 than the working population. And that trend is particularly acutely felt for male social workers, which we're unclear on what the reasons for that is and why there's a discrepancy between males and females. But in addition to what Chris has said, care workers are particularly affected. And just to add, related to the points we've made on ethnicity, we're also seeing that higher mortality is reported for NHS and social care staff from Black, Asian and minority groups as well.
Coming on to gender, the international, national and local evidence is all showing that men are at greater risk of dying from COVID-19 than women. We're seeing that both nationally and locally, and the international evidence suggests that as well. Just to add on to that, the IFS has warned that although perhaps not at greater risk of COVID-19, women may be more vulnerable to long-term labour market disadvantages in the coming economic downturn.
And finally, then, we've just included a slide on air quality because we are conscious that it's something that has been highlighted to us as an area of interest. So we've included some links to various peer-reviewed papers and that have come out about patterns of COVID-19 deaths alongside sort of poor air quality and exposure to particulate matter. So we've linked 3 papers that we think are relatively good there. With all these things, evidence is still emerging, but there are papers that are coming out to suggest that poor air quality and outcomes from COVID-19, that might be a contributing factor as well. So that's all the evidence we have brought together for this meeting. If there's any questions on the evidence we've discussed, then very happy to take them now, or also very happy to answer questions separately after the meeting.
Thank you so much both, and for a very detailed presentation and bringing new information. I certainly, even someone well versed in seeing some of these slide decks, I found it really useful, and some questions from that. Did Diana, Sandra, you said Diana wanted to come in, I think, before we went out to questions, is that correct?
Thank you, Chair. Hello, everyone. My name is Diana, and I'm the Principal Analyst at the City and Hackney Public Health team. So I will be very brief, just to add a few bits to what Chris and Kirsty have presented here. As you know, we're continuously updating our evidence, and just the last review that we've done showed that in light of what happened in Leicester, we wanted to see whether there are any trends emerging in Hackney that are similar to Leicester's. However, at the moment, current data does not show any significant increase in the cases that are being picked up via Pillar 2, which is the community testing, and no significant increases among children in Hackney. You're looking at the death statistics and the death records that we receive. We see that around a quarter of all the death certificates that are for COVID-19 deaths, they have diabetes as one of the pre-existing conditions, and Alzheimer's and dementia stand at 14% as well. That is an important finding, I think, if we would like to intervene before the tragedies occur. And another thing that I wanted to mention was we have done a bit of a detailed analysis around the differences within Hackney. So within various areas within Hackney, we looked at the wards, and we saw that there were significant differences in mortality rates among Hackney wards, and the main factors that drive those, besides the fact that some of the wards have care homes, which can increase the number of deaths that occur locally, are also the size of population that is born outside the UK. So if a ward has a high proportion of people who are born outside the UK, that's one of the factors that might increase the mortality rate from COVID-19. Proportion of households that contain anyone whose main language does not contain anyone whose main language is English. I guess that's not a very well written point, but what I mean is, if a high proportion of households do not contain anyone whose first language is English, then mortality rates tend to be high in that ward. Rates of household with overcrowding and rates of GP diagnosed dementia and diabetes. So that's just building on what Chris and Kirsty presented around the inequalities. And another thing what I wanted to show you was around the current statistics. Sorry, so I'll try to present to you, and please let me know if you don't see this. So we are developing, can you see this? Because I can't see you because I'm presenting to you.
Can see it.
Yeah, thank you. As a part of our data integration work stream, we are developing a dashboard which will help with timely information dissemination among the policymakers and people who are involved in COVID-19 response. So what we're aiming to have is all the key information in one place and accessible to the people who need to know about it. This is just an alpha version of the thing, and it will be developed with your input and with as we progress of getting data from places from other council departments and also from across the system. But currently what I wanted to show to you very briefly is the number of cases, what the situation is in terms of cases and deaths locally. So we are currently at 807 cases. And in the last week, we've had 11 new cases. In terms of NHS test and trace, we've had 32 completed cases and 57 completed contacts in total. And over the last 7-day period, that was 12 and 31, respectively. We had 226 deaths, sadly. However, that has reduced significantly since the first weeks of April, and we haven't seen any deaths in a period between 1st and 26th of June. And one death occurred in the week between 27th and 3rd of July, so recently. The number of cases has risen somewhat over the past 7 days, and the rise was higher than predicted by exceedance statistics, which is produced by the PHE. However, that increase could be attributed to an increased uptake of the community testing, which is Pillar 2 tests. There were in total 1,090 tests between 29th of June and 5th of July, which is the most recent period, compared with the previous 7-day period, where we only had 651 tests. And in terms of the pillar 1 and pillar 2, you can definitely see that most of the cases are now picked up by pillar 2 program, while pillar 1 was at the early stage of the pandemic. And looking at the distribution between the two boroughs, so City does not contribute very much to the cases. There were only 18 cases in total, and recently none at all. Most of the cases are being picked up in Hackney, which is probably not surprising given the population differences. So this is all I wanted to really share with you. Please let me know if you have any questions or you want me to come back to any of this.
Thank you so much, Chris, Kirsty and Diana, for that work, and especially I do like a live dashboard, I'm not going to lie. So seeing something that is being developed, I think is really important. And I think in terms of the people that sort of beyond the council and the health sector, that live dashboard and that ability to look at that data and those trends, I think we've all agreed elsewhere is really important for public trust. And separating out the different types of testing data and now that contact tracing data, and that appeared to be really easy to use with a good set of narrative, and I really welcome it. And it looked like a good format, and it also kind of looks like the type of things people have seen elsewhere while being sort of authentically useful to us. So again, really helpful. I've got Mark for question. One thing I just wanted to highlight from the presentation, I think it's really interesting about occupation. People had made assumptions under occupation that the occupation itself had led to the mortality rather than people having an underlying occupation and then being older. And I think that's quite interesting territory, perhaps. And just how few in Diana's presentation of testing results are from Pillar 2. And I don't know if this is sort of question, part comment, part question on Pillar 2. 3,200 tests are at the Hackney Dalston testing facility, and very few coming back positive through the Pillar 2 process. Is that because most of the people being tested there are not Hackney residents, or does it just show the kind of prevalence of the disease? I'm not sure Sandra will know fully. Well, sure. Anyway, those are my two questions. And then I'll bring in Mark, Antoinette, and Malcolm.
Do you want me to answer your questions first?
Yeah, because then we've got a neat three, if that's okay.
Okay. So in terms of
Going back on mute, Sandra.
Sorry, in terms of Pillar 2 testing only picking up small numbers of cases, it's because the proportion of positive tests it is just low. So there's a low level of circulating virus in the community at the moment, and the majority of people who are being tested are testing negative, and that could be for a variety of reasons, including that they have symptoms of something else. The symptoms of COVID-19 are actually they have a large overlap with symptoms of lots of other upper respiratory conditions, and also, of course, the test. There's a fairly narrow window during which you need to administer the test in order for it to increase the likelihood of it being tested positive. So even if someone had COVID-19 and they waited for a week from the onset of symptoms before they actually come back positive at the moment. And sorry, your previous question I didn't quite catch.
It's not that relevant. I'll just leave it in the ether.
Okay.
Mark, and then Antoinette. Sorry, Deputy Mayor Bramble, and then Malcolm.
Yeah, no, thanks for the presentation and the slides, and I agree. The active data that you showed us at the end is really impressive, actually, to see how that's being tracked. I suppose my comment was slight questions, part preceded by a comment in terms of trying to understand the data and then think how best to use it in terms of identifying people most at risk of contracting COVID, but particularly those at most at risk of having serious effects, adverse effects from contracting COVID. I just was interested in your thoughts about pointing towards the work of Julia Hipsley Cox and the group that she leads at the University of Oxford, which of course I'm sure you're very aware of, has informed creating these Q risks for others. I'll say for Q risks for cardiovascular disease, and what's your risk of developing cancer with a group of symptoms, etc., which is now populates all general practice clinical support decision-making systems that are used in general practice. Now she's developing a Q COVID risk to identify that, and her set of parameters she's using, the data include age, sex, ethnicity, deprivation, smoking status, body mass index, pre-existing medical conditions, and current medication. So very thorough, which echoes with a lot of what your data you've presented. And that will be very useful when that comes through, because that will really help target how then we identify the people most at risk, and then think how best to ameliorate that risk. I guess the other thing about it is that one of the main test centres that she's going to start using this is going to be the centre at Queen Mary Westfield College, the clinical effectiveness group, which again you alluded to, who did that research with King's that you mentioned, and talking to Dr. John Robson, who's one of the lead researchers there, he was saying that they are a test site because of the nature of the research they do at QMW. So just a hooking in there, all practices in primary care's data is extracted anonymously to inform this research. It's a great data set, as you know. So it will be really interesting for you to hook up into that, to think how that might augment how you actually use the information you're presenting to us, to kind of try and come up with a plan to help reduce those at most risk of suffering the most harm from this disease.
Thanks, Mark. I think some sort of Q COVID risk score will be really helpful for clinical practice, but also in terms of supporting workplaces and the vulnerability risk assessments they're doing for staff, where we'll be much better informed by something like that. As long as we get all of the clinical risks, all of the clinical risks into that will be really, really helpful. And yeah, we do work with the clinical effectiveness group, so that's yet another data stream for you there, Diane.
Yeah. I know you do, but I just thought
I've just responded to that.
Everyone on the call would know that.
yeah. So I think that will be really helpful to have that kind of risk score, and also but also for us to not depend on the score. And so actually thinking about the Mayor's previous question, which I've suddenly kind of understood, I think, is that about that thing about people's occupation and whether it's their age or their occupation or their underlying conditions. One of the things about people's occupations that appears to be feeding into their risk is the frequency in which and the proximity in which they come into contact with other people. And so it's not just that there are people who happen to be from deprived backgrounds and have underlying conditions who end up in these types of work. Some of that is true, but a lot of what is true is that if you happen to drive a taxi, you meet lots of people every day and you're at close proximity. And if you happen to be a bus driver, you meet lots of people every day and you're in close proximity. And if you're a care worker, you meet lots of people every day and you're in close proximity. And for the rest of us, it isn't really like that. And so they do have a specific occupational risk that's quite separate from their risk that's associated with their age or their gender or their underlying medical conditions. And so even when we get to the point where we might have a Q risk, we still have to understand what people's occupational and other types of exposure risks are and help them to mitigate those.
Thanks, Sandra. Deputy Mayor Bramble.
Thank you, Mayor Glanville. First of all, just want to say thank you for the report and thank you to Councillor Kennedy and his involvement in this and working with Dr. Hudson and the team on this. Just looking at the detail in the report, in that recently I did a webinar with Professor Fenton, and one of the points that I made in that webinar was about that COVID exacerbated the health inequalities, and what is it about the data that he was presenting? How can we distill that locally? And this report does exactly that, and Hackney and the city are very good at doing that, so that's really helpful. I suppose it's, what do we understand about the drivers, and are there any key trends going forward that we can use about the drivers forging and perpetuating the inequalities that we can use and build and bridge across to help us combat COVID while we still seek to understand it? I suppose this is a broader question and maybe not for answering now, is my curiosity around the NHS, because while we may look at socio-economic factors, we can look at overcrowding of households. If we look at the NHS and we look at doctors and consultants that have died from this, it's how are they more at risk than their counterparts in the same situation, unless they have the same unless they are linked to socio-economic challenges, overcrowding in the same way. So I just would be keen to understand that, or wondered if anyone was distilling that information and thinking about it in the way that I was. Thank you, Chair.
Thank you. Can I take Malcolm, and then I'm going to close the questions.
Yeah, just another angle, really. It's related to overcrowding and inequalities, and that is that people in overcrowded conditions are going to find it difficult to get elective surgery, because there is this situation at the moment where people going into hospital for elective surgery will have to demonstrate they've self-isolated for 14 days. Now, the impact on people who are becoming ill, I mean, I don't know whether this would include cancers, possibly it will do, could be quite significant in terms of promoting deprivation and making, taking people out of work. I mean, the number of possibilities that could have on people's lives is quite considerable. I just wonder whether this is another angle that you need to consider in the development of your report.
Thank you, Malcolm.
I think I'll just respond to that quickly. I do think that's a really a good point, that the unintended consequence of something that's intended to keep people safe is that it could actually have not just increase inequalities, but also cause more harm, and that is something for us to think about as a system. And just to respond to Councillor Bramble, that is a really interesting question, and I don't think anyone is really looking at it quite like that, probably because it's too hard to answer, but that doesn't mean that we shouldn't think about it.
Thank you. A really good questions, really good discussion, and a really good set of data and analysis, and just thank the team for that. Just on Diana's point about other data, I know that Councillor Hayhurst often, because of international comparisons, is interested in hospital admissions and people in the Homerton with COVID symptoms. And I know that that is something that hopefully we could get out of the Homerton, and we do regularly get, and I do see in sit reps. But also that sense of a growing return to any sort of second peak and wave, and whether that's possible to add to the dashboard. It's the type of information I think is held into other public health data at a localised level internationally. And I think we do have some recommendations to agree. So we've obviously, I think we would be committed to reviewing the literature and coordinating efforts locally, and Diana put in the chat that there's work at the NEL level. I suppose it's up to colleagues on this call to get in touch with the team that's presented, and possibly they could put their details in the chat, or there's certainly a point of contact for the data team if they want to sort of follow up, as Mark did in the conversation, but also other areas that they would like them to look at. They obviously are a small and finite resource, and they are drawing in data externally, and obviously having to make sense of it in some cases. But I think that is the main. Did anyone want to come back? Have I captured this kind of recommendations and the actions? Are we happy to agree?
Yes.
Agreed.
Great. Thank you very much indeed. And we've got a bit of an ask from Anne that's on just come back on there in the chat. So agenda item 10, and thank you for their patience, is Jake and HCVS's report on recovery and resilience planning within the voluntary sector. And can I thank, for the public record, the two really intensive pieces of strategic work that HCVS have done during the crisis. That initial snapshot of how the voluntary and community sector were going at the start, and they've constantly gone back to that theme, as well as the convening power that they've held throughout the crisis and the critical challenge they've provided the system. But on that note, I'll hand over to Jake.
Thanks, Phil, and hello, everyone. I'm afraid this may well be death by PowerPoint, but given we've got hardly any time left on the agenda and Jane's got an important piece to follow us, we're going to give you a very quick canter through where we are as a voluntary sector in terms of where our priorities are, what we've learned from all the different conversations and engagement we've been doing, and what we're currently focused on now. So my colleague Tony, who's the program director for Connect Hackney, is actually our lead on this resilience and recovery plan. So he's going to walk you through a very quick PowerPoint, and hopefully we'll have some time for questions. And if anybody has any questions we can't answer today, happy to pick those up outside the meeting. So over to you, Tony.
Hi, thanks, Jake, and thanks for the opportunity to come to this meeting. Very interesting thus far. So I'm going to try and share my screen. So just bear with me a second. Ooh, I don't know if that works properly. Can people see that or not? I can't.
Yeah, Tony.
No.
Actually not. I might be able to share the screen if you're struggling.
Let me a second. I think it's is that sharing though?
Yeah.
Okay. And if I just okay. I can't see you, so can someone just let me know if you can see a full screen of the presentation?
Full screen.
Yeah.
Got it.
Right. Hello, can you
Yeah,
see?
Tony, we can see it.
Brilliant. Okay. So this is just a talk through for what we've done and what we've learned, as Jake said, in terms of developing a COVID VCS recovery and resilience plan, is what we're calling it, I guess. And it's essentially in recognition of the fact that over the past 4 months, I guess, we've been in crisis mode and we're now entering recovery stage. So we want to kind of look at what role the VCS plays within that and how it sits within the wider system. So this is just some background, but just to keep it very concise. The first point I've already made. The second point is just to make sure that we've informed this with local conversations, both with the sector, with the council, with the CCG, and as has been alluded to before, the neighbourhood conversations. And we've recently canvassed wider views from the sector through a survey that we ran last week, closed on the 2nd, and we've got some findings to share, but we're still going through the analysis of that. So there's some questions that we'd like to put to the board today. Essentially, we want to find out how we can make sure that the resources across the system are more equitably distributed, because we feel that's fundamental to supporting the VCS sector recover from the VCS sector supporting the recovery, I should say, from COVID-19. And obviously the presentation that was just given highlighted the inequalities that exist, and the VCS sector we feel will play a crucial role in bridging some of those inequalities. So the 3 questions we've got for the board: what are the challenges to achieve true equity across the system? What systems change needs to happen for those organisations to compete and thrive? And are there key themes which the board would consider the VCS sector should prioritise, given that we know there's limitations from our statutory partners? I won't go through all of this, but this is just so there was a report by government that looked at understanding the impacts of COVID-19 on BAME communities, much of which has been discussed already. But there was a response from Kevin Fenton to the Equalities Minister, in which 7 recommendations were given, which are on your screen now. And I guess I'll just call your attention to the one, I'm just trying to find it, sorry, beg your pardon. So number 6. So how can we make sure that that culturally competent health promotion, disease prevention is really accelerating targets the right groups? How do we make sure that number 2, for example, how do we make sure that stakeholders within the community are really involved in developing the solution? So the suggestion there for community participatory research, which we would definitely endorse. So I guess the question for the board really is, would they also endorse these recommendations, and are there plans to adopt these locally? So just running through the themes. So this is the framework that we've been working towards. So we've got 7 themes. The first one is inequalities, and it mirrors much of what's been discussed today. But just for clarity, when we've looked at the evidence that we've received, we've touched on what we refer to as ethnically diverse communities in replacement of the term BAME. Also looking at religious and faith-based communities, migrant and refugee communities, people of working age and the impact of financial hardship, older people, children, young people, maternity, disabled people, people with a learning disability, the LGBTQ community, and also the wider impacts of structural racism, inequality and community empowerment. So when we've looked at inequalities, these are the areas that we've identified. And actually from a meeting we had yesterday, we might also add homelessness to that list as well. And then the other themes, which are probably cross-cutting themes across each of those inequality markers, will be fear and anxiety, impact of safeguarding. We know that at the beginning, the crisis mode, there were certain barriers in regards to safeguarding, but it's really important that that remains true and central to work going forward. The digital divide has been mentioned already, and the protection of voluntary sector organisations which are potentially at risk given the demands on their service, which we know have increased, but also the limitations on being able to access funding for the longer term, which is what needs to happen really to secure their place and ability to support the sector. And the final 2 themes are mental and emotional well-being, and also the mobilisation of volunteers has been crucial to supporting the recovery. There's 5 underlying principles around collaborative and partnership working, making sure that we communicate and share information in the most effective way, sustainable funding linked to what I've just been talking about, the safeguarding of the sector, tackling inequalities and building on success and innovation that's arisen as a result of the crisis. So just some key findings from the survey that I mentioned we ran literally just over a week ago. So we've seen that over 58%, well 58% for private funding, 48% have been successful in that effort. But as I mentioned, largely that's been emergency funding, and what's really needed is sustainable funding for the long term. Up to a fifth have seen a 25% cut in their funding. We have seen some positives. 73% report that they've established new partnerships. 63% note that partnership working within the sector, the voluntary sector, has been positive. 58% for statutory bodies. 55% reported, as I mentioned, an increase in demand for their services. 69% have developed new and more efficient ways of working, and it's that we want to build on. A bit worrying is that 16% are not sure that they'll be able to meet the service users' needs for the next 12 months, and we need to dig a bit more into the data to understand the reasons behind that, but a lot of that will be largely due to insecurity of funding. And then 36% in terms of reopening their service feel confident that they're able to adapt their service to meet the new guidelines regarding social distancing. 20% felt otherwise. The rest were unsure. Jake, do you want to pick this bit up, because it's more broadly speaking what we've been doing at Hackney CBS?
So yeah, thanks Tony, and just quickly, because we are running out of time and I really wouldn't mind hearing your feedback on the questions. So we've been heavily involved with Sandra and the public health team in starting to develop the community champions approach that Sandra referred to earlier. We're looking to engage probably about 40 organisations and provide them resources to be messengers, communicators, facilitators of important conversations. Thanks to investment from the CCG, we're about to roll out funding, small and large grants to charities to be able to deliver COVID responses over the next 12 months. You've heard a lot about the neighbourhood conversations we've been facilitating. great way of bringing people together from different sectors and backgrounds. Tomorrow at the ICB, we're going to be talking about a new operating model for the VCS, and alongside that, there is plans for a new VCS enabler workstream as part of the ICS, where we can look at our own strategy, but also work with the public sector on how we integrate more fully than perhaps we have been doing today. And then some of the other bits are about this sort of classic role that we play as a CVS, which is providing a space to hear from local communities, doing a lot of work around mental health, a lot of work around young people and policing. So I'll probably stop there, Tony, because I really wouldn't mind getting on to a conversation if at all possible.
So just to conclude then, we'll take forward any further feedback to help further refine our plans, and similarly this is an evolving document and we'll be responsive to that. Timelines will suggest that we're hoping to finalise our collation of further input and start development of a strategy from early August. So yeah, onto the questions if we can. We've got 3 that I've mentioned before, so just to as a reminder, what are the key challenges to achieving true equity across the system? What systems change needs to happen for those organisations to compete and thrive? And are there any key themes that the board would consider that we as a sector, the voluntary sector, should focus given the limitations on the statutory partners? And I guess just to reinforce what was, I guess, came up in one of the Equalities presentations, is around the disproportionate impact for African heritage communities, and our survey revealed that actually they are the ones most reported instability and most fearful of risk of collapse. So it's really how do we support those organisations in particular, given the need for them. If I can refer back to the chair to chair a bit of discussion or field questions. Thank you.
Thank you, Tony and Jake. Questions or comments from colleagues? I'm really pleased to see the CCG fund, because I know that's been an intensive piece of work, and if we're endorsing that tomorrow, that's even better. Colleagues? Or is it Councillor Salmon and then Councillor Bramble?
Hi, thanks, Councillor. I think it was just on question 1. So one thing I'm conscious, so for some of the work that Lisa Rain and others have been doing and linking in through neighbourhoods and other routes about how we could be better at either through developmental work or through how we were adapting, how we were doing things in terms of working with a range of different organisations. What I'd be quite keen to hear back from you is what you have heard in terms of feedback of what the barriers have been to organisations in terms of either working over the course of COVID and the work to date to help inform sort of the next steps around about that. I think we've been trying to be quite conscious about how we do think about that, particularly as we move into the second phase, including taking into account a lot of some of the conversations that HCBS have already facilitated. And I guess it would just be helpful if there's anything more granular that's come out through the surveys to help inform that as well to move into the second phase, about how we can make sure we're best set up to make sure that we've got a really good representative set of organisations that we're working with in the second phase.
Tony, do you want to go?
Well, I was just going to say, so we are still going through the analysis, and we do have a lot of. So what I've provided there is more the quant side of the stats, but we do also have a lot of qualitative data that we're still going through. But yeah, I can definitely come back to you and share that. But Jake, if there are any further insights you want to give now?
I think what's been great is that some new community organisations or initiatives have formed around food, which I'm sure you're aware of.
Yeah. I
think there are a lot of organisations struggling with the notion of reopening, and we've been providing a lot of training, working with public health on that. I think there are, like the lunch clubs, for instance, some real pressures on them. Similarly, some of the youth organisations. So I think it's a mixed bag. What I'm really interested in, though, however, is that, as we've all been in emergency mode, and the council has spent, 70-odd million itself in responding to this crisis. If we are really serious about utilising the voluntary sector more in the future, we really need to think about a significant resource shift. We need to understand how much money is going in at the minute, and really how can some of that resource locally, I mean, the ICB is responsible for £537 million worth of spend. How can we shift that resource so that communities themselves are empowered to be in the forefront? Because without that, we're going to lose organisations, and they're not really going to be able to give you as statutory partners the reach that you need into communities that perhaps don't engage so readily. And it's really warming to see in Jane's paper a focus on co-production, and I think that will help us understand what's needed going forward.
Thanks, Jay. I just want to correct the record, not spent, lost.
Lost.
Yeah. So in terms of spent, it's closer to 20 additional million. And a lot of that going into things like PPE and care packages and things like that, rather than. But Councillor Deputy Mayor Bramble wanted to come in.
Very quickly, thank you, Chair. Councillor Selwyn touched on some of what I want to say, but I'd be keen to understand, even before the co-productions, what the organisations are saying themselves around what the challenges and barriers are, because I think once we understand that, we can then build up and bridge across how we then meet the challenges to empower the sector going forward. And just a quick comment, thank you for your report. One of the things that you highlighted was institutional structural racism, and I think that we didn't pick that up in the dialogue before, but we have to consider that. And also in terms of the second question, what system change need to happen for those organisations to complete and thrive? It's not just those organisations, but the system itself, how we look at ourselves inwardly and think about how do we address the disconnect and go on that journey around cultural competency through that work. So thank you, Chair, and thank you again for your report.
Thanks, Councillor Bramble. I mean, Phil, we're probably going to have to stop there, I guess, because you've got more speakers and zero time.
Yeah, we have run out of time, and that's very kind of you to recognise that, Jake. We are losing a few people, I think, because of that. I think what Deputy Mayor Bramble said is a really important trigger point around next steps. The other bit I was going to say that would be helpful for me, and I don't know if it'd be helpful for colleagues on the call, is some analysis of the different sectors we're talking about. So if people's competency as an organisation is effectively a pathfinder community leadership role, or if they're working with young people, or if they're working in food, or if they're working with older people, or they're doing a combination of all of those things, because they're effectively in sub kind of commissioning markets and grant markets, and your point about competition and collaboration. And we do see that challenge where we've got community-based, often ethnically based voluntary sector organisations that raison d'etre is representation often, but they're having to jump through different hoops to try and access funding and almost mould themselves into a different type of organisation, and that can create some challenges. So it'd be really useful, I think, to see what type of providers are out there. And the lunch clubs are a really good example. Those are well-established organisations in one part of and I hate to use the word market or sector because it's kind of not the type of language we'd want to use, but that effectively is what people are doing. And I think that would be quite an interesting, if you're still crunching the data, because there are also frameworks that we want to change, how we commission youth services and those sorts of things, and who's in and who is out currently of those frameworks at the moment. But that, I think we'll have to stop there. Maybe we can make sort of the evolution of this an item earlier on in the agenda next time we meet, so that we see what happens over the summer. And obviously there are other outlets for this conversation too, but I think it's really important that voice was heard here at the Health and Wellbeing Board today. I'm now going to very, very quickly move on to item 11 and Jane's report, which, as Jake said, does have synergies with what we've just been discussing.
Thank you.
Thanks, Chair. I'm hoping you can hear me all right. My sound's all right. So I'll go through this quite quickly. I'm not going to go through the whole paper. I'm assuming you've read it, and it does build on a lot of what we've discussed. So basically, the paper's about the role of this board in improving population health and tackling inequality. So it builds on discussions at the your March meeting, where a health in all policies approach was endorsed. So to focus the board's attention on a move more towards the wider determinants of health. I'm assuming you all know what they are. I'm not going to explain what they are. I'm happy to answer questions on that in the interest of time. So that implies a role for the board in coordinating local action across a whole range of policy and service areas. And so that was what you talked about in March. And the inequalities exposed and reinforced by COVID that we've talked about a lot this evening have clearly created an urgency and a renewed focus for this work. So we thought it would be timely to bring this back to the board now. It's also timely because the health and wellbeing strategy needs to be, well, overhauled really, so it needs a refresh. So the paper proposes a framework for guiding coordinated system-wide action for the greatest impact on tackling health inequalities, and it describes that in terms of having to take action against 4 pillars of a population health system. This is a King's Fund model, and it's increasingly being taken up across the country, and I know ELFT had a challenge session where the King's Fund helped facilitate that last week, so local partners are using it too. So this basically says that there's a key role for integrated health and care services, really important, but not the main driver of population health. Most importantly is coordinated action across these wider determinants of health, so education, employment, housing, etc., etc. That is where the greatest contribution to population health and inequalities lies. We also need to make sure that our prevention programmes are fully aligned for maximum impact to tackle barriers to healthy behaviours. So these are socially patterned themselves. So things like alcohol consumption, diet, smoking, physical inactivity. Lots of great stuff going on locally, but not necessarily all aligned and not necessarily targeted appropriately, as Tony mentioned before. And then fourthly, but really importantly, is this focus on needing to work in our places with our communities to develop solutions with them that will have a lasting impact. So none of this is new. We've been talking about this sort of thing for a long time locally, but what the King's Fund presses home, and I think that is what we're seeing now, is there's not really enough attention. There's not the right balance across those 4 pillars in terms of where we pay attention and where we invest our time and resources. And also crucially, the greatest impact, according to this framework, is the areas of overlap and intersection of those 4 areas. So in that Venn diagram, the bits that sort of overlap with each other. And that's about all parts of the system working together in a coordinated way to achieve common objectives. And this is where the health in all policies approach comes in. The neighbourhoods approach is really relevant here. And we've got some very specific, really good examples of this, like the King's Park Moving Together Sport England pilot, which is working very much using an asset-based community development approach to implement solutions to address the low levels of physical inactivity in that area. So that's just one example. So in terms of taking this forward, so to enable the board to effectively coordinate this system-wide action, we're proposing widening the membership for a broader perspective and greater influence across those 4 pillars. Again, I think you discussed this at your March meeting, so this is picking up on that discussion. And the paper also proposes that in refreshing the joint health and wellbeing strategy, we use this population health framework with an explicit focus on reducing health inequalities, and to establish a working group to oversee the development of this. It would have been quite helpful to talk about what the membership of that group might need to be, but I don't know whether we'll have time for that today. And probably one of the most important things that, and then Jake mentioned this, we're seeking endorsement for a fully co-produced approach to doing this. We not only need to better understand what's driving the inequalities, but we need to sort of shape the response to that in partnership with our residents and communities in a really meaningful way. So using the asset-based approaches that HCVS have been doing, building on that great work that Jake and Tony have been talking about, but there's lots of other work that's being done by partners, and we should be building on that. There's a real opportunity here. So obviously, before I finish, we shouldn't wait for a new strategy before where there is actually clear action that needs to be taken now. So, for example, tackling the digital divide in the sort of new world of virtual by default service delivery. But we do need that to happen in parallel with developing a longer term strategy so that we can guide our future priority actions for this board in particular, thinking about where do we focus attention, where do we add value. And we can use this framework for both the short term and the long term actions. I think I'll stop there and take any questions, comments.
Thank you, Jane. I really appreciate that and the energy that you've brought to that at this late hour of the agenda, and really welcome the ideas that you've set out there. I think in some pre-conversations there's the whole economic side of the determinants of health, and some of the levers within the council aren't really properly represented here. I know Councillor Williams has joined and is one element of that, and I know she's very keen to be involved bridging that link between inclusive economy and inequalities, but that's not the only voice. I've also know that coming out of our discussions around a response to Ofsted, and I don't know if Anne might want to come in, there was a discussion around how we hold the agenda around young people, and whether or not there's a role for the Health and Wellbeing Board here. And then obviously your point 10 clearly says we need a sort of working group or subgroup around developing that strategy. And so any questions or comments sort of around that?
Just to heartily endorse the paper and the thrust that you outlined so well, Jane. At the middle of those four rings, that point where projects like as Kings Park, as you said, sit, where actually you can see all four of those coming together. I'm glad. I want to thank Jake for stopping early and giving you time to talk about this, because it is absolutely vitally important, and these two papers do link into each other. And co-producing with our voluntary sector partners at a neighbourhood level is what lies in the heart of those four circles. And this is a first step on a good way towards doing that and improving the health outcomes for everyone in our communities. Thank you.
Thanks very much, Mayor. And I'm slightly worried about landing this with Sandra without in advance, but one of the commitments we made on the back of the Ofsted report was that we both respond to the Ofsted report and actually have a wider partnership policy about what it means if you're a child brought up in Hackney, what expectations you should have of the community and the services that are there for you. And if we have a joint partnership, if it's a policy plan or a strategy with any meaning, it does need to have partnership involvement and therefore partnership oversight. And so much of it will be dependent on the wider determinants. So we had this exploratory discussion that perhaps the Health and Wellbeing Board could have some role in that, but had not yet spoken about it. But we had a discussion with it at the Members Oversight Board last week. And I think it's very important, and therefore it's probably worth an airing, which perhaps I can come to you, Sandra, and your some of your key colleagues in public health to talk about it in a kind of wider sense. I just want to slightly land it there at the end of the meeting. Thank you.
Thank you. I noticed as under 5 there are no direct financial implications. That's probably a sort of true on one level, but obviously it does require true commitment to partnership.
It's a not at this stage.
At this stage.
So
yeah.
of this paper, there are no direct financial implications. We're very precise in public health.
I can tell, but the rice miles are precise as well. So I don't want to lose sight of the fact that even if it's human resources, they are going to be required. Other questions, comments?
It's Mark here. Sorry, I had to just slightly disappear for a moment, and now I'm back again. And I've been listening throughout, and I just wanted to a quick, short, snappy thumbs up from myself, from my perspective.
I suppose I do think, thank you. I do think we need to sort of understand, and there's places where this debate has already been held, like at the Community Strategy Board, but the role of public sector anchor institutions and what they do and how they act and how they collaborate. And it does link into how they fund and what they hold within them and what they put out to the community. They are big elephants in the room, and unless we're sort of very clear that we're going to change the way we do some of those things or understand why we're not, there's a lot of unanswered questions about how we sort of behave as a broader partnership. And I think there's good stuff, good practice, good seminars, good breakfasts, all sorts of things have taken place around that agenda, but we now need to sort of bring it into action and do some experimentation and look at some of those the good practice that you cited. But there are other things. We had a discussion around where we get our stuff and what our local market and economy looks like, even something around PPE, but it's around food, security services, cleaning. There's loads of things that could be done in a better way, and the whole care system obviously itself, as we've seen in terms of has been. So I think those sorts of things really interest me, and I suppose making it accessible as a process as well, so residents understand that we're on this journey. But I really do welcome the recommendations, but we do have to, make them happen as a collective. I think we're all signed up, Jane. Now you just got to make us do the work.
Just a small thing. Okay, so in terms of how we work through who we want to sit on the working group, because we can go away and do some work and bring some stuff back to the next meeting, but I suppose do you want to do that now, or do we want to just sort of come up with some proposals and agree separately outside the meeting?
I'm not sure we're going to be able to agree them now, but we can charge, I guess, a forward plan. I did discuss with others, I don't think, given we're at this developmental stage, that meeting quarterly is enough. And we've seen that with the agenda. So you've got a heart and key people in. You've got part of the agenda that's COVID crisis, part of the agenda that looks to the future, and then there's the board itself and its needs. And I think we don't like a away day culture at the moment across the health system. So I think we probably do need some thought about more regular meetings while we're just at this developmental phase, if we're going to nail this and keep track of the crisis too. So maybe that's our offer, that we say yes to this, we do the work in between, and we try and reconvene twice in the autumn winter period rather than just the once that's currently in the forward plan, was my proposal.
Okay. Can I suggest that we bring back proposals for the wider membership of the Health and Wellbeing Board to the next Health and Wellbeing Board meeting, but in between, we, as in Jane and I and colleagues, will work on the membership of the working group, and that perhaps a board member like Councillor Kennedy could be the chair of that group, and we can take that membership to him to approve.
Happy to.
Thank you.
Brilliant, thanks.
Yep. Good stuff.
Excellent, thank you very much.
That means that Councillor Kennedy is picking you for football, basically. Okay.
You're on mute, Phil.
Sorry, last item, and I hope Donna's still with us, because I know she's going to be playing a much bigger role in the work and the development work around the Health and Wellbeing Board with colleagues, and is looking at this draft forward plan. I suppose I've jumped ahead a little bit, that I think there's probably more that we would want to do, but I'll hand over to Donna to introduce her paper very quickly.
Thank you. So yeah, as was mentioned, I'm Donna. I'm from the Hackney Public Health team. There is a paper attached to this that I hope everyone's read, and I will whiz through it quite quickly in the interest of time. Can you hear me?
No, it's Antoinette Bramble calling back. Is that okay?
Antoinette, you need to go on mute. Good. Yes, we can hear you.
Okay, brilliant. So this last agenda item sort of sets out a proposal to develop a health and wellbeing forward plan, as you just mentioned, using a health and all policies approach. I think we've talked a lot about health and all policies and health inequalities already, but just to quickly set the context for the proposal, Jane's already mentioned previously that the Health and Wellbeing Board meeting in March, there was a proposal that the board adopt a clearer focus on the wider determinants of health through a health and in all policies approach. And there's growing recognition of the importance of improving and maintaining people's health and reducing health inequalities, I guess especially at this time, as we've mentioned throughout this meeting, when they're so apparent. And as was mentioned already, we are and continue to take immediate action to address the inequalities linked to COVID-19, and have heard of specific examples in this meeting, but we also need to be strategic in order to tackle inequalities at a local level more longer term, as Jane mentioned in her item. And one of the ways we thought we could do this was to address it through our wider work outside the healthcare system. So what we're proposing is taking a health and all policies approach. So decisions taken across local government and local health systems have the potential, obviously, to create conditions for healthy lives. And this would be adopting a cross-sector approach to improve health well-being and health equity. So focusing on joined up decision making across the multiple services, programs, and policy areas that we have. And within that, I guess, highlighting the health, well-being, equity, and sustainability consequences of different policy and decision-making options. So we're proposing that the Health and Wellbeing Board is well placed strategically to implement a more systematic approach to this, and to ensure that all local relevant policies are considering the wider determinants of health, and that's during the development of the policy, but also in implementing it as well. So I guess in terms of sort of taking this work forward, we're proposing how we could address this locally is to use a Health and Wellbeing Board forward plan that adopts a health and all policies approach. And what that would look like would be taking a systematic approach to using the Health and Wellbeing Board meetings to review the key local strategies or policies. And these would be selected on the basis of their expected significant contribution to population health as well. And I'm not sure if everybody has had a chance to read the paper, but there is an example of what that might look like in the appendix of the paper as well, if you want to have a look. So it outlines some policies we might want to look at. The list isn't exhaustive, and the rationale for selecting those as well. So we thought that the forward plan could be designed to provide timely input into strategies and plans as they come up for review, and that would give the board greater influence on reducing health inequalities and improving population health. I won't go through all the different areas, but local policies that the Health and Wellbeing Board forward plan might want to include are transport, housing, economic inclusion, children, young people, leisure, green space, education, and so on and so on. There's lots that we could have a look at. And so I guess to conclude, the recommendations that we're proposing for the board would be to use the Health and Wellbeing Board forward plan as a framework for action to review local policy, and just to ensure that the social, economic, and cultural factors that influence health are considered within the policy development and implementation. And then the second part of that obviously would be to monitor that implementation of the policy through an inequalities lens to see what their impact is on the health of the population and the vulnerable groups within that. So yeah, as I say, the paper contains a lot more detail, but that's sort of a quick tour of it. And I'll hand back now, and we're happy to answer questions on that.
Thanks, that's really helpful. I personally looked at that list and thought that probably, given the discussion we just had, that the inclusive economy strategy and children and young people probably are more important and more things that will influence us in either direction. I do know things like the review of choice-based lettings and things, which is a sort of subset of our housing strategy, is kind of more imminent, and it might be that given what I'm trying to think, Malcolm talked about the impact of housing and the interaction to poor health. I suppose there's a challenge for all of us of using this mechanism to challenge other parts of the council and parts of the system, and that's going to be a cultural shift because they won't have been used to being challenged in that way. I think it's really important they are. And I do wonder if there's strategies outside of the council that we would want to bring in that partners have and apply some rigour so that it goes in both directions. And I know there's places where some of those are held elsewhere, but they're not else. I think the commitment to sort of health inequality that we've talked about across most of these meetings is something that we've sort of reserved for this body rather than the ICB in terms of some of the operational strategic split. I don't know if, Sandra, you wanted to add anything to that, or colleagues wanted to come in. And if we aim to sort of finish at past, if people can tolerate, then that probably gives us a few minutes just to finish this off.
Yeah, thank you. I just wanted to add really that I think it will be a challenge to people, whether it's from inside the council or from other organisations, to have their strategies scrutinised in that kind of way. It may feel as though we're trying to undertake a scrutiny function, which is not what this board is set up for. But it's not so much that we are trying to step into somebody else's shoes, but more that we're trying to support the implementation of those policies in a way that has the most impact in terms of improving population health and reducing health inequalities. And certainly within the council, most of our colleagues in other departments have said that they embrace that, and they will tell us quite gladly that they've put something in their strategy or their policy that supports that. But in terms of how that's then implemented or how it's prioritised within that strategy, that's something that is not really being evaluated in a way that we can see what the impact on health is. And this is a really good forum for looking at that, and also in particular for looking at the intersections between those things, so that we understand that where the inclusive economy and housing strategies both intersect to improve health, as opposed to doing these things quite separately that are both about improving people's lives, but are doing it with very different perspectives, and also without putting health as their first priority. So this is really an opportunity for us to enable that.
Thank you, Sandra. I thought Chris was reaching.
Only I was only going to write. I agree with Sandra in the chat.
In the chat we're not using.
Indeed.
Apologies, Chair, that was a bit mischievous.
No, mischievous is good at 1826. Do you have, Donna, Mark, were you coming in?
No, I was just going to say, it is interesting. As Sandra's saying, this isn't a scrutiny committee. It's also interesting, isn't it, when people are developing policies, to know, they wouldn't want to wait until they land at the Health and Wellbeing Board before they receive the feedback in a way. I mean, obviously people will know that they will be questioned, so therefore they will hopefully be bringing health thinking into their planning way before they come here. So it's just an interesting idea of how the reach of this group will affect people sort of upstream in their work. They're not waiting in terms of when they come, just in terms of the sequencing of things. It's an interesting challenge, really, and I guess people will get used to it once they come here. It's not intended to be a scrutiny, but it sort of is, because if we're not seeing it, we'll be going, where is it? And then we would expect people to, amend their policies accordingly, I guess, because that's presumably what we're expecting of ourselves.
That is a good question about how do you get the health priorities and the reducing health inequalities as a priority into people's policies and strategies in the first place. And we clearly do need to do that work, and that's part of the work of this board as well. But having said that, of course, there are some existing strategies, and that doesn't mean that we can't shape those as well, rather than let them play out and say, oh, we'll wait 5 years till they do the next one.
Yeah, I agree. But I completely agree, and I think there's an element of sending Donna away to find out which stages and which align most with our agenda and in which order. We don't put anyone to the back of the queue because we'll always put certain things, but I think there's some that are in active development, there are some that are in implementation, and clearly do have, as Sandra said, in the housing strategy, there is a look at the impact of poor housing on health in the private rented sector. that had a burst of activity around it when the strategy was launched, and some pilot collaborative work between private rented sector and public health. And then it sort of sat, and there's lots of reasons for that, and we have to be critical friends rather than sort of judgmental, but I think it's really important that we sort of have some awareness of where we can have the most impact. That's all I was sort of seeking and suggesting, really. Are we happy with that general thrust? I think it's also how we use the meetings. I think you can only take one strategy per meeting like this and give it the justice that it deserves, and I think that's the scheduling challenge. Imagine if we had a strategy as well tonight. We would not have made it through. So, but agree with the recommendations if we can.
Agreed.
Thank you. Brilliant. I didn't get notified of any AOB. I had one of my own, but I'm dumping it into outside of this meeting. I don't know if any colleagues have any AOB. You should have notified me technically beforehand. Nope.
Nope.
Well, great. Thank you so much for everyone's work. Thank you for persevering. We only lost about